Welcome to the Turd Nerds. We are the functional gastroenterology podcast discussing all things poop. Before we take the plunge into today's episode, let us tell you a bit about ourselves. I'm Dr. Rebecca Sand, a naturopathic physician and acupuncturist, and I specialize in all things gastroenterology, hormones, and fertility.
I'm Dr. Ami Kapadia, and I'm a medical doctor trained in family medicine and functional medicine with a special interest in gastrointestinal health, food and environmental allergies, and autoimmune disease.
And I'm Dr. Lana Gurvich, a naturopathic physician and acupuncturist who is board certified in naturopathic gastroenterology. I specialize in inflammatory bowel disease, IBS, and other functional digestive disorders. Let's jump into today's episode.
The following discussion is for educational purposes only and not intended to diagnose or treat any diseases or conditions. Please consult your doctor before incorporating any of this information into your care. The information presented on this podcast is not medical advice.
All right, welcome back, everyone. We have got yet another case of bloating and constipation today that Dr. Sand is going to lead us through, which I'm sure will have various fascinating details, like always. Take it away, Dr. Sand.
Yeah, and it's not as straightforward as
It never
would
is.
like, so otherwise we wouldn't be talking about it. But I do have some notes I am reading off of just because I'm not getting some of these details right about it, not mix it up with a bunch of other people. So anyway, this was a 34-year-old female when she started seeing me, and she traveled a lot. So
Professionally for work?
No, just for fun.
Okay.
Just, someone who traveled quite a bit in 20s and whatnot. And she came to me for bloating, weight gain, cramping, and intermittent constipation.
Okay.
That's a very generic patient.
That's like everyone we see, which was part of the reason I was like, oh, this one might be kind of interesting to talk about. But when she had looser stool, which would kind of happen in between the episodes of constipation, it was sticky and lighter in color. And that was sort of like the basics. So brief little like timeline background on her. Constipation and heartburn started in childhood. Yeah.
Like 5, 6, 7, or like
elementary.
Okay.
Yeah. College, she ended up having a colonoscopy for the constipation. They found hemorrhoids. The doctors basically told her, eat some fiber, try not to strain, which is like not helpful for anyone. And the fiber made constipation worse. She went to colorectal surgery, got some hemorrhoids taken out. That left some scarring, but it's overall like fine. The hemorrhoids are overall okay. In her 30s, constipation worsened, bloating worsened, weight gain worsened. And she ended up having an abdominal x-ray. That was the only other like imaging that was done, showing moderate stool burden and gas, essentially. So some of the questions that we all ask when someone comes into us, that just, for more background here, antibiotic history. She had quite a bit in childhood for sinus infections, ear infections, that kind of stuff. Really just in adulthood that she could remember, 1 UTI. So not terrible.
So like 1 or 2 rounds a year for a lot of her childhood? Does that sound right?
Yeah. I think it was like a condensed period, but and then no abdominal or pelvic surgeries, because we always ask about that. Probiotics, I always ask about a trial, how did that go, better or worse? She said it didn't really do anything, but she couldn't remember what kind. So as we know, there are a lot of super bogus products on the market that would do nothing if you took them. I always like to ask, if you took antibiotics, did it help with your gut stuff? If you took antifungals, like for vaginal issues or toenail fungus, did it help that stuff? And people are always like, oh, I haven't thought about that, She also hadn't remembered, but, I do ask. Food poisoning history. So this is, the travel stuff coming in here. Multiple times, Mexico, Ecuador, South America, quite a bit. I like to ask if you can remember what you ate.
Why?
Because if it's like meat-borne versus water-borne versus like a veggie,
Just making conversation.
I just love to know. No, I think more parasite protozoa, raw fish.
That makes sense.
Versus like, post-infectious IBS.
Yeah,
kind of stuff.
That's a good question.
And people remember, they're like, oh yeah, it was the taco, or like, oh yeah, it was ceviche, right?
What do you think?
I don't know. I feel like a lot of the bugs can live on anything, but you're right. If it's certain specific, we know there's a food association with that
versus
animal product.
Yeah, right. Like an apple you didn't wash,
right?
But yeah, anything can grow on anything. No parasite protozoa testing she's ever had, and no family history of digestive issues.
Okay,
that
so
she knows of.
That matters for her inflammatory bowel disease, but not a ton.
Right.
Right. Okay.
Yeah.
That gives us information.
So what she's trying, gluten-free diet didn't help, and in fact, she thinks she gained weight on that. She did do SSRIs, and that also caused her to gain weight. She tried low dairy, and this did reduce bloating somewhat, but oddly did not help the constipation.
Okay.
In anyone who has an atopic childhood or, the chronic ear infections, I'm always curious about a dairy sensitivity for those folks, because that in adulthood might manifest as gut issues. But she resumed eating dairy. I think she does low dairy, actually. And then she did try Trulance for a bit of time, and she kind of uses that on and off.
Because it has efficacy with not a lot of side effects.
Right.
Okay.
So, there was some win there. She just didn't want to be on drugs, and it didn't do anything for the bloating.
If you want to learn about Trulance, we do have a constipation pharmaceutical episode entirely dedicated to that.
Yep, lots of great options out there, and lots to know about those options. So, what makes her worse? Alcohol?
Any alcohol, beer, wine, hard liquor?
Great question. I don't remember.
What's your thought process with that?
Just it's fermented stuff like beer and wine versus like hard liquor doesn't have the
or sugar. There's one with sugar. Yeah. And then
you could have her. I'm just kidding.
She had a really random thing of food sensitivity. So dried fruit was a notable one. A lot of FODMAPs.
Okay, so dried fruit is tricky for me because I'm like, is there sulfite on the dried fruit?
Yeah,
sugar, concentrated sugar.
Enough dried fruit, everyone gets gassy.
Moldy.
You can't, and it's addictive, right? Because it's straight sugar. So that one is a tricky one. Yeah, and mold, of course.
FODMAPs, you said.
FODMAPs.
Yep. Like beans. I think she was okay with garlic and onions. Yeah, she was okay with garlic and onions, but she couldn't do beans and she couldn't do cruciferous.
Okay.
But those are gassy foods.
Yeah.
So it wasn't clear cut.
Yeah.
She said she did okay with sugar, but who knows? And then sometimes I'll ask about white rice and carby things. Those were fine.
Okay.
So, she did do Miralax, but it helped her sometimes, and she didn't like taking it. She said psyllium didn't help her, and then I asked how much, and she said she took 1 to 2 cups per day during the trial.
So not very much. That's maybe
quick question: if someone's on Miralax and psyllium, they should separate them, or no? It's fine to give them both at the same time.
The only reason
it's come up recently.
Are you asking because psyllium absorbs?
I just want to know what you guys do, and it was in my list of questions to ask.
For things that are powders, I don't really see that. So psyllium just acts as an osmotic.
So it's fine.
Miralax acts as an osmotic.
Right, like magnesium.
So it's just going to draw water, and so is psyllium.
Okay.
The risk is with pills, tablets especially, that the psyllium is just going to gelatinise it up.
Okay, thank you.
Get absorbed.
Check it out.
I'm positive no one's studied that.
I'll go with your gut.
Okay, so that's sort of, and then she did do digestive bitters that helped a little bit.
Okay.
Visit 1.
Did you tell us what she eats?
No.
Okay. Not important.
It was an open diet. She tried to avoid dairy because it made the bloating somewhat worse.
Gotcha.
Cutting out dairy didn't solve the bloating.
Okay.
So visit 1 follow-up.
So that was my intake.
Okay.
What did I do visit 1? I gave her magnesium citrate. I mean, we always talk about, if people are constipated and bloated, see if you can just get them pooping and save them money on testing, right? So put her on magnesium citrate, told her to drink water, because no one drinks enough water.
Good idea.
Poop if you're dehydrated, especially on magnesium citrate, with electrolytes. I ordered a broad panel of labs, as we do, because they hadn't been done in years, and I included celiac testing, and that went for her.
And she was actively eating gluten.
She was actively eating gluten. Visit 2, so reviewed these labs, negative celiac, magnesium didn't work because she didn't titrate it up high enough, everyone doesn't read the instructions on that. Bloating is worse. Now her PMS is flaring. Her labs showed her B12 was at 302, which
I think consider low.
A lot of us would call low or functionally low. Ferritin was 7.
Very, very, very low.
So iron deficiency. C6 is fine.
I was just doing a deep dive on ferritin.
Yeah.
What I want to clarify, what I'd like to clarify is ferritin is a marker of intracellular iron. It's not iron. It's not what's circulating. That's hemoglobin and hematocrit.
It's a storage form.
Intracellular. Yeah. And that's super important because the other things that are intracellular are mitochondria and all of the other functions. And so if you're low ferritin, all of the processes that are intracellular are missing this huge gas.
That's why you're so tired.
Yeah. It's amazing. I just never really understood that.
It's the number 1 micronutrient deficiency in the world.
Yeah.
Yeah.
And every female, it's such a
not every female. Not
a lot.
Oh.
It seems
okay.
Yeah.
It's a rare bird. Especially for our population where they have digestive issues and are probably struggling to absorb iron anyway.
So I just want to give our listeners who are all over the country and all over the world at this point, really, mainly English-speaking countries. They seem to like us more. But at this point, you don't even need a doctor's order to order your labs. You can go to Quest Direct. You can go to LabCorp Direct. Any of these national labs are now allowing you to have direct to consumer, and so you can run your own ferritin to see. and it's not technically always iron deficiency anemia. It's an intracellular iron issue.
It's not anemia.
Right.
So it's iron deficiency. If your red blood cells, hemoglobin, hematocrit are also there, then you have anemia. But it's iron deficiency with or without anemia, depending on your CBC. The only cause of low ferritin is iron deficiency.
Yeah.
But high ferritin can be a whole slew of other things. So.
But if it's above a certain amount, then it's very unlikely that it's from their inflammatory condition. Like, you can still rule out iron deficiency a lot of times with the ferritin.
Yeah.
Because if it's more than like 200, 300, it's very unlikely they're going to get it that high. Just from inflammation if they have a low iron. You know what I mean?
Well,
I
I've
asked this
seen
question
it in the
recently.
500-600s in liver disease.
But that's an inflammation.
Right.
But then what I'm saying is, like, I used to think if they had inflammation, how am I going to rule out iron deficiency with just the ferritin? Obviously, we get all the iron studies, but sometimes they're confusing to interpret when you get all of them.
Right.
So if the ferritin is already like 250, 300, even if they have inflammation, it's very unlikely they have iron deficiency. I recently asked this question.
Huh.
Yeah. And then I just want to, I know this isn't technically an iron ferritin episode, but I also want to say,
it's relevant to all my cases.
I do utilize a transferrin
right.
as a panel to make me see if the transferrin is within
related.
So
the transferrin saturation. You mean the saturation?
No, I mean transferrin.
Transferrin receptor protein.
Yeah.
Okay.
Is inversely related to ferritin if ferritin is elevated from inflammation.
So the higher the inflammation, the lower the transferrin.
That's right.
And that's a marker that I use a lot with my inflammatory bowel disease patients.
Right, to see. Because ferritin can be a useful marker for inflammation in some folks.
Exactly. It's an acute phase protein.
Right. So
it goes high in acute inflammation. Right. What Ami's saying is the likelihood that it's going super high and also their iron deficient is not high.
Right. And if you do the full panel, the transferrin saturation, there's also cutoffs on MD Calc to tell you what's consistent with iron deficiency based on that calculation for males and females. So I will check that too if the ferritin's sort of wishy-washy.
And I'll say that tracks, because for IBD patients, for like ulcerative colitis, Crohn's folks, they're super low ferritin all the time in active flares.
Yeah, true.
So that makes perfect sense.
The inverse of what we just talked about. Yeah.
Okay, sorry, back to this.
Okay. So her labs came back. She has no iron, she has no ferritin, she has no vitamin D. I mean, her vitamin D was low, it was 27. Which I'm glad I tested for celiac, because those can be early identifiers of many, many things, but also celiac. Tune into our celiac episode. So I added those nutrients. I ordered her iron infusions because she was very, very low and tired and her hair was falling out, and I recommended a SIBO test.
Okay, that makes perfect sense.
She's loaded. And then I revisited this magnesium citrate instructions and just told her to ramp that up a little bit further, because it will work if
I'm sure you checked the thyroid, or she probably had it. Okay.
Yeah, in my broad panel that I'm sure we all do similarly. It's all this metabolic, lipid, everything, but especially thyroid with the bowel.
I just have to throw this in. I had a guy whose TSH was like 25.
Wow.
He was on thyroid medicine, and we just bumped him up one increment, and it normalized. Like, this is
so
crazy.
12 micrograms, like something.
Yeah,
like that.
it was just, he knew it was off, but I was like, that's
Did
crazy.
You take
that
biotin before?
No, I tell them now you can't take biotin or B vitamins for 5 days.
Yeah, that's good.
Anyway, I just had to throw that in. I was like shocked that it shifted that much with such a
So
tiny dose.
just so you know, I have experience where exactly same story, and I move them up like 12 micrograms, and then they swing to being hyper, like pharmaceutically.
So something else is going on.
Yeah.
Okay. Anyway, that's for another day.
And just one more thing, just on that, I have been doing this long enough where if I am chasing a thyroid around, like every time I'm running every 3 months, MTHFR, like you have to look at their methylation and detox pathways. That is a clinical pearl that it took me years to figure out.
Because otherwise they're not going to metabolize the thyroid hormone?
Because I think what's happening is not that they're not going to metabolize thyroid hormone, they just don't do it on a cadence that's regular with how they're taking their thyroid hormone.
Okay.
So it's swinging.
So could you just give them a B complex with methylated B vitamins if you think that's going on?
Yeah. Okay.
That's what most of us do anyway. That's what I gave her. So, so her SIBO test came back positive. You want to guess?
Oh, methane dominant.
Yep.
How dominant? Do you know?
I don't remember, actually. I didn't write it down. But I, in her case, decided to treat with herbs because I was unclear about a Candida SIFO picture as well. She did have some of the food triggers, and I didn't test for that. This was back before we had our SIFO episode.
Okay.
So anyway, I just did the herbal treatment. And then, as we treat SIBO or microbiome issues, generally it's like a multi-course kind of thing to kind of replenish the microbiome. Anyway, she started feeling better. nutrients. I monitored them. They replenished for her, especially with that iron infusion. She was able to exercise more, improve bloating. She fell off my schedule.
Okay, I love that.
Not the end of the case here. So it was something around like 9 to 12 months or so. She came back. She wanted another SIBO test. All her symptoms were back. And typically in these cases, I asked some questions that could cause SIBO to come back. So did you get food poisoning? Did you need a course of antibiotics? Did you travel anywhere? Again, she has. So none of those things are really lighting up. And that's really like, are we really dealing with SIBO, or did we miss something in the first case that predisposed her to SIBO coming back? No surgeries, nothing. So she had the same kind of food triggers. She was still doing some of like our herbal prokinetics as part of, generally our SIBO treatments. They kind of helped. PMS was worse. Fatigue was back. Her psych and P put her on Wellbutrin.
Okay, that makes sense.
So at that point, I decided to order
Oh,
her.
I'm sorry. Can I back up?
Mm-hmm.
That ferritin of 7? What did you do about that ferritin of 7?
Infusions.
Okay.
And it normalized.
Okay, cool.
Yeah.
Okay.
I ordered her a broad stool panel to see if there's anything like deeper microbial coming back on her. And the only thing that came back on the test I ordered was Dientamoeba fragilis, which is kind of a debated parasite protozoa, know.
It's somewhere between those two worlds.
Exactly. So, and nothing else. So her secretory IgA was like borderline, but zonulin was fine. Elastase was fine. Steatocrit was fine. H. pylori was fine. No evidence of biofilms, no candida, like nothing came back. It was a relatively boring. So for me, in looking at, the protozoa parasite-ish, I was like, sure, but that doesn't really explain, what I'm seeing.
For some people.
I did treat it.
Okay, let me explain.
I mean, I've had people with one protozoa, and they're like, some people you treat them and nothing happens, and other people you treat them and like, I'm good.
I think the way I think of it, I probably got from your brain, is it's sort of just like, that tells me you're hospitable to things. But why? You know, like that thing's floating through you. Maybe if we would have done this test another time, or 6 months prior, it would have looked different with different things. But like, why is that happily living in you?
Good question.
And I maybe it was causing everything for her, maybe not. But I put her on a repeated SIBO treatment. I just added in some anti-parasitic herbs because I didn't have any evidence of something that I would want to like hit over the head with drugs. And let me see here.
That's one we usually treat with pharmaceuticals.
Yeah, that is one that I would generally. I think it's
do for
consequential.
No. But I can't remember. I think it might be on my website.
It's actually no. It is definitely on your website because I go back to your website every single time.
That's why you made me keep it.
Yeah, yes. I mean that and the water filtration. If you guys have never been to Ami's website,
it's really pared down at this point. But
the resources are there.
The resources.
The water filtration. The water filtration is so useful. Ami over researches everything. The world needs to know this information. Yeah. And she's done the work for you.
There's some good carbon monoxide detector as well for anyone.
People underestimate.
Low level detection.
Which methylene blue treats.
That's right. That's right.
Okay.
So I put her on kind of like a broader spectrum herbal thing that had like an artemisia, lower dose, some black walnut, things that might treat parasites, protozoa. Bloating improved slightly after that. Walking helped. She's newly dating again. And now she comes to tell me she has pain with intercourse. Her periods have gotten heavier.
Oh, I know where this is going.
She's having some period issues. So we go into more of that history, and periods have been fine for a long time, except adolescence. Things were bad. But I was like, let's order a pelvic ultrasound.
Endometriosis?
Sorry.
I mean, you do a lot of endometriosis.
I was going to say in the beginning, like, you guys can probably guess where this is going to go.
Yeah.
I did not guess that in the beginning.
Rebecca's like an expert in endometriosis.
Yeah, that's why I want to talk about it, because there's a big correlation with that and recurrent methane-positive SIBO.
Okay, so finish the case and then let's go there.
So her transvaginal ultrasound came back with a hemorrhagic cyst on her right ovary.
Oh, which you taught us is basically endometriosis.
You really want to be careful with those. Yeah, it was large too. So I think it was like 3 centimeters. So I sent her to an endo-specializing gynecologist. They did a laparoscopy with excisional and found it on the bowels. And they couldn't take that out, unfortunately. But they did plop hormonal IUD in, which she was okay with.
Because are we gonna let's get through the case and we'll talk about why that matters.
Okay. And I got her in immediately, after the surgery, as soon as she was able and cleared to come in. We do adhesion management and try to make sure, because endometriosis itself will cause scarring in the pelvic and abdominal cavities, depending on where it is. endometrial lesions, a lot of people don't know this, but they respond to our signals from our brain just like our endometrium would, and they bleed. And that internal bleeding essentially is what it is: bleeding on top of the ovary, bleeding on top of, I think she had it on some
low
ligaments. Exactly. So that low of iron, always I'm like, we got to screen for this, especially if it goes back down again, and it did for her.
And she didn't have that abnormal of cycles.
No.
Or heavy menorrhagia or anything.
No, it wasn't too bad. She had a history of it, and then it came back when she resumed, a sex life. But maybe, she just, it was more on her forefront of her mind then. But the pain with intercourse piece, especially, what we call deep dyspareunia, it wasn't like, introitus opening. It was deep, and, different positions could help it, but like, why?
Yeah.
So that always is like a red flag for me. So anyway, she got it out, and we did a lot of abdominal therapy. I always put people on N-acetylcysteine because we have evidence on that decreasing progression and growth.
So that data is N-acetylcysteine, I think 1,200 milligrams daily, is on human endometrioma post-surgery endometriosis, showing it decreases
recurrence.
Adhesion formations post-surgery.
Okay. Yeah, so most people treating endo, you're just going to be on some level of NAC. Yeah. There are like a whole slew of things that we talk about for people, and we have episodes on endo. You can go back and listen to those. I did retreat her SIBO after the surgery. And what I followed up with on this one that I didn't on the previous ones was I put her on stronger prokinetics and talked about we're probably going to be on these long term. Especially on and off, you have any inkling of symptoms coming back, and some kind of like walking, movement, yoga. You have to move your abdomen more than you had to in your past, because very likely there's still adhesions from the endo. It's still, the IUD is going to keep the signaling down, the bleeding down.
So the theory of IUD and endometriosis at the moment, do you want to explain it?
It slows the signaling to the endometrial lesions to grow and expand and respond to the cycling.
Is it because it's like a lower level of estrogen?
It's actually not estrogen.
Or progesterone. It's a progesterone only.
And
progestin.
Okay.
So what they have found is that endometriomas are very insensitive to progestins or progesterone. So if you super saturate the area with progestins, that actually slows the growth of endometriomas. So the treatment of choice.
So they don't get the normal estrogen cycling, like the peaks, right?
You still, with a Mirena,
will you still get?
You're still going to ovulate. I think it's somewhere between like 15 to 20% the first year of having it. After that, you do actually ovulate about 70 to 80% of the time.
Okay. So
but
you're still
those
getting
signals are kind of protected from the endometrium and endometrial tissue
because of the progestin
locally, because of the progestin, and you're not growing, expanding, endometrial tissue quite as much, which can lead to the pathogenesis of it growing.
And you're not growing it as much because of that signal. Because of that signal.
So what triggers endometrial, again, we have this whole episode, but what triggers endometrial tissue to expand outside of the uterus is cytokines, so immune dysregulation, which is why SIBO treatment is so important, as well as your microbiome directly can cause that. We have reversed endometriosis by doxycycline in animal models. It's wild.
Only outside of the, extra uterine endometriosis, can you reduce it? You
don't have endometriosis in the uterus. It's only defined as lesions outside the uterus.
So I'm talking about adenomyosis and such.
Totally different. Yeah.
Okay.
Yeah.
Okay. So we're just talking about external tissue.
Yep.
Gotcha. Okay.
Yeah. It still responds to the same signal. So if it plops anywhere, if you're still setting those signals, that's why mainstay has been birth control. Shut the system down, stop the signal.
Okay, that was the traditional way we would treat
and now we're treating a little bit more with progestins or oral micronized progesterone.
Okay, because we used to think it was just shutting it down.
Yeah, which works for some people. You might want to take it out first in some cases, but you can kind of shut it down.
Take out the endometriomas.
Yeah.
And so doxycycline in animal models. Anything else?
Well, there are a lot of microbiome studies on it at this point of we can actually induce endometriosis with dysbiosis. So you can't forget that in the treatment of your endo, folks. Even if they don't have gut symptoms, and this person did. She had endometriosis on her bowels, which is tricky because it's so vascular; it's hard to remove.
So you get that to decrease anyway with decreasing inflammation and cytokines without surgical.
I put folks on anti-inflammatories. I put folks. We do a ton of fiber and antioxidants and whatnot. I do calcium D-glucarate to just everything that's going to help estrogen detoxification. So we're not recycling estrogen we don't need, whether they're on birth control or not, to kind of get that down.
Sorry, I have so many questions. This is not my area.
It's early, yeah.
Do people often have because I was thinking like more do people often have adenomyosis with endometriosis or not necessarily, right?
I think I've seen like 2 or 3 cases.
You're not usually common, so there must be different pathways.
Yeah, both are underdiagnosed like crazy. I think endo is getting a little bit more traction because people can see stuff outside in weird places.
And adenomyosis, would we get clues on the transvaginal ultrasound?
You can get clues on
it.
Yeah, it's also misdiagnosed quite often for people. But
we have that one patient we used to share with the adenomyosis.
I know. Yeah. I'm thinking like
they can be debilitating.
Intuitively, I would think they would both go together, but they don't usually. So.
Yeah, and a really good treatment for it is menopause, right?
For both.
Post-menopause. I mean, you want to get through it. Perimenopause
and for fibroids,
rough because your estrogen relatively goes higher. Yeah, fibroids as well. So you want to think all
late
of that
menopause,
as estrogen
late menopause.
Yeah. And sometimes we induce menopause for people to just shut it down if all the other symptoms aren't right.
So that's Lupron, right?
There are a lot of options. GnRH agonists, and you can shut down the ovaries early if you want. Yeah.
I feel like what I'm visualizing is light switch off, but it's not actually.
That's sort of what birth control is.
Yeah.
We market it as being like a way to regulate the cycle, but you're not.
You're shutting it down.
You're stopping essentially a lot of communication between the brain and the ovaries, which can be really helpful, but can also cause a lot of issues.
Yeah.
We don't inform people well enough, I think, on what that does to folks. But anyway, back to this case. For her, now with her bloating and all of that, it wasn't just like a microbiome thing, which tends to be where I think bloating first. Something's producing gas for her. I'm really thinking of structural. I'm thinking of inflammation because folks with endometriosis are inflamed. Like that's one of the drivers of it. We have to get that inflammation out. That alone will induce leaky gut, cause food sensitivities, cause bloating, all of that for people. So it's like, yes, she's going to be predisposed to SIBO because of the adhesions in her history, but that almost was like exactly secondary to something else manifesting. So always do a thorough review of systems. And check out, gynecologic conditions. We don't have a lot of space in our you want to make sure
it's always so tricky for me. What is a diagnosis that walks in that I dread the most? Is it fungus? Is it constipation? Is it that you stumbled on endometriosis? Because that is hard and you need a team.
You need a good team, but it's so common, and there's so much we can do naturopathy.
And there's some really good surgeons in Portland.
Really
specialize in it.
Here.
I just had a patient. She's one of my favorite. I love her. The first time she came in to see me, I had a student in with me, right? And I had her hop on the table and I palpated her abdomen, and I was like, this is a huge effing cancer. It feels like the size of a football. Yeah. It was the size of a football. And I was like, we need to, like, this week, I'm calling my local radiologist who I trust more than anybody else to do women's health. And I'm like, where do I send her? What do I do? I was like, endometriosis and a huge ass fibroid. Yeah. And it was taking up so much space. Yeah. So she went to go see a local surgeon. Yeah. And when she just had her surgery, actually. And when she had her surgery, the nurses kept on being like, where are you from? Where are you from? And she's like, why? And she's like, because everybody who sees this surgeon is from a different part of the country or the world. Oh, wow. Because the surgeon is so specialized in these surgeries. Yeah. And she's amazing. She's also a beautiful human being. Yeah. So.
Yeah, it's a good one to have on your radar for bloating because endo alone can cause bloating. But any kind of growth that's impinging on blood flow or digestive flow, fibroids are a huge one. And it's why I've palpated some huge ones too. And like, how did you not know this was there? But people are unaware of their bodies, and if it's causing trouble for them, they especially don't pay attention because no one's helping them.
Except in the middle of the night.
But that people with endo have a guarding. In their lower abdomen. It is, I touch a lot of bellies, but it feels tense. Yeah. Constipation can do that too, but not as much as endo. It's like, it knows it's inflamed and it guards.
So endometriosis, fibroids, adenomyosis, all estrogen driven. Yeah. So some of the other estrogen detox tools could help too.
For sure. Yeah. Get that liver working. Yeah. Number one, get the bowels evacuating. Mm-hmm. That is like,
get some space.
And estrogen
recirculation goes down.
Yep. Yep.
Oh yeah,
And then-
even just getting the bowels moving,
Yeah,
oxygen
right.
circulation.
Exactly. You
goes down.
have to start there, and then you can work your way up and work on the liver and
Yeah.
all of that. But microbiome evacuation are number one. And again, I think we talked about it in our bloating episode, but what really helped her a lot was walking.
Yeah.
Like, none of us move our bodies enough, and I encourage people.
I walk every day.
I know, you're
Good
a
for
champ. I
Don't
think
you?
I'm about to start another 100-mile bike challenge, so I'm gonna start biking
It's
again.
amazing. Biking.
Yeah.
But the other thing that I want people to do is not just walk straight. Like, try to take curves, try to go on trail walks, like, move your pelvis in weird
I
ways.
try to walk in a straight line on the same path. That's usually
Treadmill?
what I end up doing. No, not outside, but it's the same.
Outside's better. Yeah,
It's the same path.
Yeah, and you don't have another blood. But
Thank God, knock on wood.
Who knows
Yeah.
what we have?
That was a great case. Okay, here's my silver
Reminder.
lining.
Yep.
If they're a man, they can't have endo.
correct.
So at least 20% of our population, we don't have to think about endo.
Yeah.
That's the only silver lining I had come up with through this
Yeah.
case.
Yep, have gynecologic conditions on your radar. It's usually
Yeah.
part of my intake. You know,
Yeah.
even family history. We always ask about like family history of gut issues, but family history of gynecologic
Yeah.
issues, because there's a thing called silent endo that can
Yeah.
be just as
Ugh.
inflammatory. And yeah, it kind of stinks from a clinician standpoint, but if you figure it out,
Yeah.
people
Super
are better.
helpful.
Yeah.
Yeah.
Thanks, guys.
Thank
Thanks
you.
for joining
See
us.
you next time.
Thanks, Dr. Sand.
Thanks for joining us today. Stay tuned. We release episodes every 2 weeks.
If you like this episode, please subscribe and don't forget to rate and review us to help spread the turd nerd word.